and the patient stopped appearing. And what happened was now we find patients presenting with much later presentation, much more advanced disease in hematological malignancies. What we do know is that 8 to 10% of our patients diagnosed with hematological malignancy from all the cancers. So it is a significant number. So some statistics. Now this is data data obtained from the HPCSA annual report 2020-2021. So we got 11.5 million people in cases and registered in our medical database. We got 998 diagnostic radiologists, 997 family medicine doctors, 965 physicians, peds 1,050, hematologists 146, anatomical pathologists 293, radiation oncologists 246, and for pediatrics 7, surgeons 871, clinical hematologists 6, with just 7 pediatric hematologists. Now, in public sector, we have 6 clinical hematologists for both Johannesburg and Durban. In private sector, we have 4 clinical hematologists based in Durban and 1 in Johannesburg. So we quite a small group of specialty. Saying that some of the oncologists also treat lymphomas and not really keen. The team approach is always warranted in this kind of scenario. The first person that usually sees these patients are your general practitioners. The thing is, they also can form part of the core team as well as part of the non-core team, because it depends on exactly where your patient is referred. So if the patient is locally in Johannesburg, I would probably be the doctor attending the patient. But if the patient comes from, say, Moira, then the GP is the closest doctor that's going to take care of the patient. But the patient is always centered to this team, because we have people like pathologists, surgeons, radiologists, oncologists, and physicians, everyone forming a team to manage, because these patients can sometimes be very complicated. So how would they present? Cough, unexplained bruising, bone pain, joint pain, or abdominal pain, frequent infection, tiredness, unexplained fever, unexplained rash, unexplained weight loss, shortness of breath, pain, drenching nitrates, lumps, swelling. Basically, any one of these combinations of signs and symptoms can present with many of them, not necessarily much, but we'll always start off with the basics. Full blood count, blood smear, infection marker, CRP, ESR, UNE, LFTs, maybe an ultrasound, chest X-ray, or biopsy if the patient presents a mass, because we need to screen what's causing it to paint a clearer picture. So basically, what we're trying to do when we look at the blood results together with clinical presentation, anemia will present with breathlessness, fatigue, palpitations, thrombocytopenia, easy bruising, neutropenia, recurrent infections, increased metabolism, weight loss, sweating, fever, splenic enlargement, discomfort in the left hypochondria, anxiety, occasional preferred pain in the left shoulder. And then signs then of obstruction or pressure, lymph nodes in the neck, axilla, suprarachnoid area, and luminal regions. And then bone pains, deep, intense bone pain, or pain around the ribs from fractures, which is usually associated with myeloma. Hematological malignancy is easy to classify. So basically, we have the myeloids and the lymph. Under the myeloids, we have active myeloid leukemia, myelodysplastic syndrome combination of myelodysplastic syndrome and myeloproliferative and myeloproliferative. And from the lymphoids, we have lymphomas, chronic lymphocytic leukemia, skeletal cell, and then acute lymphoblastic leukemia. So it's easy to know what we are dealing with, but it wasn't always the case. So initially, we all studied this in university, where the FAD was diagnostic criteria, where we looked under the microscope, saw the number of blast cells, saw the morphology of the cells, counted the blast, together with the cytochemical states, myeloperoxidase, non-specific esterase, and we were able to then classify active myeloid leukemia from M0 to M7. Say, yes, this is what. Then WHO came on. They published this around about 2006, 2007, the tumors of hematopoietic and lymphoid tissues. What this showed us, we could now look at specific genetic lesions, chromosomal abnormalities, monosomy 7, we can now tie in with the morphological FAD criteria, M2, M4, M5. Translocation A21 with an M2, translocation 1517 with an M2. So what does this mean? It means that now we've got a second method to actually confirm this patient got malignancy. Now, to make a diagnosis of active leukemia, you need more than 20% blast blood or bone marrow. But in an M3, as an example, even if the patient got 5% blast, as long as the translocation 1517 is positive, we can say this patient got an active myeloid leukemia, promyelocytic that requires emergency treatment. So you don't need 20% blast. Then just before I wrote my final exam, this guy's published the next book, 2009, around about there. And then we have to study a little bit more. Because now, instead of just looking at the chromosomal abnormalities, they also include the molecular abnormalities. And what this helped us do is to better risk stratify this patient. So we now able to say, yes, you've got a better risk acute leukemia, you've got an intermediate risk acute leukemia, and you've got a poor risk. Not like acute leukemia is a good risk, but in any case, we are able to determine that certain patients, certain profile would respond better to treatment, then we could actually manage it better. So WHO gave us this in summary: epidemiology of malignancy, clinical presentation, whole blood count of differential findings, bone marrow acid and peptide counters, immunophenotype, cytogenetics, molecular prognostic markers. So what this means is that what we report in South Africa is similar to what we find in the UK, the US, New Zealand, etc. It's standardized because we all use the same reporting mechanisms. So how does this help us plan our treatment? So once we know what we're dealing with, we make a diagnosis. And we spend a little bit extra time on making the diagnosis because every little information we have, we're able to then plan what type of induction. Besides just the induction, it also helps determine what other alternative treatment. So once the patient goes into the condition, are we going to do allogeneic transplant? Are we going to continue consolidation chemotherapy or do an autologous transplant? If not, are we expecting the patient to fail? And if the patient is in fail, should we now be looking for an alternative treatment method, some clinical trial? So we know what's considered good risk factors and what's poor risk. Emergency treatment is standardized everywhere. The first thing we're going to do is ensure ABCs, airway, bleeding, circulation. Then the next thing we're going to do is treat complications of the transfuse blood products, high antibiotics, infection, influence. Now, blood products is a little bit tricky. We don't use normal rates of concentrated. In fact, now Sanders is now moved towards leukodepleted blood. We prefer to do leukodepleted blood because once we give chemotherapy, we immunosuppress these patients. Immunosuppress them, and then if there's any viruses or anything in those lymphocytes that we transfuse, that can cause problems. So what we do is we'll give single dose apheresis platelets as well as leukodepleted red cells. So we try and limit the exposure of blood to these patients. Sometimes we can actually go down to a hemoglobin of 7, not worry about it. Platelet count of 10, not worry about it. We have ITP patients with platelet count of 1, 2, wouldn't actually worry about it because there's nothing we can do immediately, and we'll only keep platelets on hand, but give it to a patient if they actually need it. So we will not necessarily give them platelets unless it's high risk, GIC. And then we'll also treat emergencies, fractures, compression fractures, GIC. So the investigation we'll do upfront will include the bone marrow, immunophenotype, cytogenetics, molecular tissue biopsy. Others would be the next generation sequencing. physiology. If we had to look at the peripheral blood up front, we would, if we saw this kind of picture, these are acute pulmonary blasts. It's got a typical morphology. We make the diagnosis based on that. We can actually start the patient on treatment before we do the bone marrow immunocytogenetic, because the morphology doesn't change. And if we did the bone marrow and saw a whole lot of cells looking at this, which are plasma cells, we know that we are dealing with the patient already presents high monoglobin peak, anemia, raised calcium, etc., renal failure, fracture. So we're able to determine our way forward. So treatment targets. In the 1970s, 1980s, this is the patient profile. We give the patient everything and we hope for the best. Patients knew that the outcome of having acute leukemia or lymphoma or myeloma or whatever, the prognosis was poor. So some of them decided, you know what, not going to take treatment because it made us more sick, which was true. Because we gave them everything, we didn't know the correct doses or the correct combinations. Then after giving quite a bit of those drugs, we were able to find that a few of these drugs did better than others. So we basically started homing in on what worked and what not. But still, two patients died because of the complications of treatment as compared to the complications of treatments. Then we found out that if we give good combinations of therapy, we can actually reduce the dose of certain medication and have very good targeted therapy. But some of these treatments still had high risk of complications. And then Paul early coined the term the magic bullet. What he meant by the magic bullet is that every individual malignant cell in the body has a unique common protein or antigen on it. We can identify the antigen. We can make a bullet to target that specific antigen. So keep all the healthy tissues aside, and the treatment will go specifically for that cancer cell. Kill it, and everyone is a winner. So the treatment strategies became simple based on that. Therapies are based on mechanisms that target critical molecular pathways. Therapy must be specific and safe, must have a high therapeutic index. We have effective treatment when we achieve a dose below the maximum tolerated dose. So we don't have any side effects, patients continue the treatment. And if used in combination with traditional treatment modalities, reduce complications. And the last thing is, we now have oral chemo drugs, intravenous, subcutaneous. We use a combination. We reduce side effects. So the evolution of treatment. Not all treatment that was developed in the early past of our years are bad. If you look at CHOP and EPP, EPP is used for Hodgkin's lymphoma. It's still considered a really good treatment modality now. The patient is diagnosed with Hodgkin's lymphoma today. My regimen would be ABVD. The patient failed that and go to the next step because ABVD works. So in 1975, it worked. We can still use it. But then over the period of time, with science and research, we developed newer drugs, much more potent drugs. And we're currently looking at drugs called CAR T cells, which is very specific. Okay? So CAR T cells is a chimeric antigen receptor. So basically, we know a patient's got a type of malignancy. We go in, we remove your T cells, take your T cells, put it in the lab, introduce that T cells to that antigen that is found on that cancer cell. It takes it in, we grow those T cells in the body, give it back. Those T cells now home in straight to those cancer cells because it's now being modified. That's how specific we want. So CAR T cells work. The thing is, it's not readily available. We're trying to set it up in South Africa. We do have patients that go abroad and have it, but it does work. So we have many bullets in our gun these days. So how do we decide on combination? We all know this from our second year physiology. We have different first phase, synthesis phase, second growth phase, and mitotic phase. And basically, in each one of these phases, we have a combination of drugs because no way it tells us that every cancer cell is in the mitotic phase at one. We have a few percent in the mitotic phase, a few percent in the first replication phase, second replication phase, whatever. So we need drugs that will basically cover all these areas. So stem cells, why are stem cells so important? Because it forms part of the treatment modality, but it's also the cause of these malignancies. Stem cells have three distinct properties. Self-renewal, develop into multiple lineages and proliferating cells. Tumor-initiating cells have the above properties are known as cancer cells. Now, multiple pathways and processes are required for formation of cancer stem cells. And what we do know is that usually the patient might have the predisposition for cancer, but may not necessarily have it. And you require a second hit, whether it's radiation exposure, some viral, some drug, or just by chance something happens in the body. That second hit then converts to a normal stem cell into cancer cells. That stem cell then forms a primary tumor. Fine. Now, the concept of stem cells, especially in the leukemic stem cell, can vary. So it could be your primary tumor, could be the reservoir for your resistant or relapse, it could be involved in NETs. So basically, this would be your primary tumor. If we treat you with chemotherapy and one cell is refractory to all the treatment we gave you, after a few months, you might find another lesion. That is your relapse. If that cell escapes from the primary tumor and goes and get lodged in some organ, lung, GI system, liver, over a period of time, it will grow and then you find your mets here. The only reason we're able to find all these different types of tissues is because of the scientists that work on these cells, malignancies, acute leukemia, the lymphomas, the myeloids, the lymphomas, Hodgkin's, non-Hodgkin's. And basically, we have to find them because they were able to determine the various pathways that are involved in production of gene expression. Because this is where the trouble occurs. At this point, that we have these cancer stem cells, the leukemic stem cells that proliferate more, refuse to die, become resistant to treatment. And if we identify all of these markers, then treatment can easily be directed to one of these markers and so we can reduce the dose of overall treatment by targeting the individual pathway. And because we know that mutant genes have been implicated in leukemia pathogenesis, genotypic diversity of leukemia is vast. So we can't, every time we have leukemia, genotype it and then find a specific molecule that will work on that. We currently have the genetic molecules that work broadly speaking, but at some point we probably have to look at specific lesions. Now, chromosomal translocation and point mutations in the leukemia target pathways that control the survival advantage. So when we talk about gene directed, this is still underdeveloped. We are trying to protect identifiable genetic abnormalities, promote selective protein synthesis and regulate selective proteins. So basically, we want to make sure that that cancer cell dies, it does not grow. And this is how we're going to do it. This is where, in fact, in trying this in hemophilia, so we have an adenovirus there. If we know what gene we want to stimulate or inhibit, we put in the genetic coded adenovirus, inject it, or it goes into the nucleus, releases that genetic material. That expression of that genetic protein would now either cause the cell to die or prevent it from proliferating, thereby reduce risk. But even better still, this is next generation sequencing and karyotyping. Now, these panels are getting larger and larger. Soon we'll just be able to take maybe a drop of blood, run it through this analyzer, because of a whole list of possible genetic lesions that we have. And if we find one genetic lesion, say IDH1, we know IDH1 can use certain drugs. But if we know that and we say, yes, based on your history, your parents' history, your family history, the chances of you developing into leukemia is high. Maybe we need to treat you, pre-treat you prophylactically like a vaccine. Give you something that would try and switch that. If it switches it up, you're just a karyotype. Now, if you look here, it's 9 and 22. This was the first Philadelphia chromosome translocation 922. Based on this, we were then able to develop molecular treatments to target CM. So, antibody targeted therapy. We all know this drug, toxic therapy. It's a kinetic antibody to bind CD3. There's your antigen. This is your non-Hodgkin's lymphoma. It's got that antigen. That's what Paul Erdős was talking about. He says, you've got this antigen. We can make an antibody that attached. Make an antibody attached. So 90% of non-Hodgkin's lymphomas have this. So we can use this antibody as a target. And it's well tolerated. So what could we do? We got the antibody. We know it's got a specific target. We can attach any number of these aminocytokines, immunotoxin, immunolysosome, radioactive ligand, radionucleotide. So basically, it will go into that lymphoma and kill that individual. That sounds good. Our molecular directed therapy, Gleevec or imatinib for CML, is a specific inhibitor of several tyrosine kinase. ABL-related gene product CPD receptor, and it induces complete hematologic and cytogenetic remission in most patients. So if you've got a patient with hypertension, diabetes, asthma, whatever, patient can still be treated like a chronic disease. So we give you one tablet every day, take it, and after a few years, we won't have cancer. That's how simple it is to treat CML in the chronic phase. But obviously, there are a few patients that will probably not respond to Gleevec and require a second generation AI and wait up. Do all CLLs require treatment? So when we see a CLL patient, majority of patients, as they climb up the ladder, that they might develop lymphocytosis. If you do develop lymphocytosis, it's not very hard. Then we would then say we can continue to monitor. So if a lymphocyte count is greater than less than 5, we would say it could be just a monoclonal B-cell lymphocytosis, nothing to worry about. Keep an eye on it. If it's greater than 5, we'll probably say, let's do some flow cytometry, immunophenotyping of these cells to see if they got the phenotype of CLL. If they got a phenotype of CLL, they still will not qualify as long as they don't have any other problems. No large mass rate, no large spleen, no large lymph nodes, no hemolytic process, no severe anemia, low platelet counts due to autoimmune condition, no significant weight loss or fever, constitutional symptoms. They probably wouldn't then qualify for treatment. But even if they did qualify for treatment, so the later stages, RI classification or Vinay classification, the treatment that we have is steadily improved. Our first line treatment, and if you come down here, you will see fludarabine, cyclophosphamide. We're using a combination of chemotherapy and a targeted therapy, toxin. So what we do is we attack the cell from all sides. We get good response. Do all plasma cell disorders require treatment? Not necessarily. MDAS, monoclonal gammaglobuline undetermined significance. You will find the monoclonal need to be of low volume, say 8 grams per deciliter. We wouldn't actually do it as long as hemoglobin is fine, calcium is fine, kidney function is fine, serum free nitrogen is fine, and there's no lytic. We wouldn't actually do a bone marrow. There is a probability that an MGUS patient might move forward. Even if you move forward to what's called smoldering fibrosis, so that means they achieve the minimum amount of plasma cells in bone marrow, but no anemia, no lytic lesions, no hypercalcemia, no kidney function, normal serum free nitrogen, not greater than 1 hour. We we still wouldn't treat the patient because what we find is that treating these patients do not go an advantage. We'll only treat the patient with myeloma if they activate one of these criteria. And if we treat that, we have a whole lot of drugs. We could start off with rhubarb and orange peel, like what we did in meeting before, to treat myeloma. Or we could go giving them just peel and feeding and hope for the best. But these days, we've got drugs that are so potent that we have really good responses to myeloma patients. Myeloma is considered an aggressive disease. And usually these patients would have to get stem cell transplants, auto stem cell transplants to consolidate to the overall survival. But some of the drugs that we have, they are so potent that we can actually give these drugs orally. So a patient with myeloma these days probably doesn't even have to come to my rooms to get it. Come in there, they'll get all the tablets. The combination of tablets, they go back home to my river and they take it to home, the comfort of it. So no more IV chemotherapy. We can probably get away with some subcutaneous chemotherapy. That means 5-10 seconds in the room, one injection, you tell me similar to taxane or a steroid shot, and you continue. That's it. The only problem is that sometimes, because these drugs are so potent, you can have some peripheral neuropathy, but things that we can manage, but it will definitely control the COVID-19 and hematological diseases. Once you got COVID, we couldn't stop the treatment. We hold the treatment. Because, in fact, what we found mortality is higher if you got COVID and you continue the treatment. So what we would do, we would stop the chemotherapy because it's immunosuppressive. Give you time to recover from the chemo, from the COVID, and then restart the chemo. The thing is, we can support you regarding blood transfusion, platelet transfusion, and keep your cancer in check until you recover. The problem is if you have severe COVID pneumonia and stuff, then it just adds to the stress of the body. We're looking at transplants. So in conclusion, the remarkable specificity and ability of targeted directed therapies offer great promise to fulfill the role of magic treatment of disease. We are no more shooting the dark. We are looking for the targets and we directing them to them. Highly specialized laboratories are required to daily treat malignancies. We no more just look at the blood under the microscope and say, yes, you've got a cancer. We're looking at specific molecular genetic lesions because we are going to direct therapy to those lesions. And chemo is essential to diagnosis, because if you don't have the GP, you don't have the physician, the radiologist, pathologist, and pathologist all working here, you're just never going to achieve all the targets we treat. We need to treat early because it's less complications, and we need to treat hard. I've always told my patients, if you take any new medication without the knowledge, then if any problems come along, you would have to deal with them. So majority of them will take newer so-called cannabinoids, all of these things. The problem is we have no idea how these drugs will interact with some of our newer agents. They might have used it previously with the older treatments, but because our newer agents are so potent, we need good commitment from patients, good commitment from families. The patient will not fight cancer. They need families. It comes with too much of damage. So teamwork is essential. Family is important, patient is important, families. And above all, the nurse. I think it's International Nurses Day. The nurse is the one that will give you the most amount of information. Patients tend to open up to nurses more than doctors. So if your nurse is good, able to look out for side effects, explain side effects, and address side effects early, you shouldn't have patients. Thank you.
So in general,
3 tablets.
it's 3 tablets.
3 tablets.
3, that's the patient takes for myeloma, the only issue with the it's 45,000 for the site, which is much cheaper than what the season parts will just. So the patient takes 1 tablet per week for 30, and they get ready to 28 day cycle. So
it's given a day 1 day, and it's tablets together with a little bit 28 day cycle, so it takes 21 days. That combination has good results. The thing is, this using all 3 drugs are oral. The patient can take the medication, oil, purple, plates, Newcastle, with no issues as compared to the injectables. That comes with the boost. It does come with a benefit.
What is the sort of realistic turnaround time of the laboratory to get enough time to be able to select agents? Obviously, not the simple things like myeloma.
So, from a bone marrow point of view, we usually sign up our bone marrow unless we're waiting for some additional staining or markers. From a genetic point of view, within 5 days, 5 working days, we should have some genetic results. NGS probably takes about 10 working days, but it takes some time to process that. It's a large panel. The panel that I showed you is from so it's quite an extensive panel. We can start treatment early in myeloma because the first line treatment is kind of, but once we find out if we have a 17p deletion and stuff like that, then we can be able to modify our treatment. So upfront, we do get a majority of centers would actually wait for the results to come back, because remember, the patient had myeloma for a long time. They've been smoldering for a few months, a year before that was any gas. So waiting a little while is not going to complicate.
Just how the medicated investment will be
Yeah, you see, all medical aids got set formulas. So they'll tell you you could use X, Y, and Z, and it might be a generic form of instead of the original drug. So you would have to go there. The thing is, some patients, based on the plan option, if they have the lower tier, they might not have access to the high end drug. So like the discovery patient top end package will probably get majority of the drugs. Maybe 1 or 2 you will still have to motivate, but they will get it as compared to the lower tier. So sometimes low tier you may not get injectable cortisol. You might have to go with thalidomide. The thing is, we've got data to show that all these drugs work. So the thing is, if we can prove that patients don't respond well to one drug, they will definitely take the other. But majority of oncology plans covers about 200,000, 400,000 in some of our plans. You'll probably still require some gap because the medication comes at a cost.
maybe you could also add the outpatient assisted program.
Yes. So some of these companies do have patient assistance programs. So that means if we need to use a drug and say one of the medical needs say you need to do 25% co-payment, the company absorbs that fee. So the patient can still have access to the drug. It's just that not every company offers those assisted programs, but they are. Any other questions?